Okay. We're going to go over the CBO for open and closed suction for the neonatal rotation. We will go over a bit of background knowledge and what is expected of us as students to successfully complete the CBO. Suctioning should never be done on routine. Suctioning should only be done as needed. There are many hazards that can result from unnecessary suctioning, such as mucosal damage, hypoxemia from sucking the air out of the lungs, atelectasis from applying negative pressure to the lungs, arrhythmias, hyper or hypotension, increased ICP, infection, and bronchospasm. The suction levels for the neonatal population for open suction should be set at negative 50 to negative 80 millimeters of mercury, which it is set at now. For closed suction, we want to increase the suction pressure by 10 millimeters of mercury. So if we had it set on negative 80 for open suction, we would change it to negative 90 for closed suction. To select the suction catheter size, we can use the formula ETT, inner diameter, times 3 divided by 2, or we can use the formula ETT, inner diameter, times 1.5. They'll both give the same answer. So step 1 is assessment. The patient should be assessed to determine if they need suctioning. Signs that the patient needs to be suctioned include visible secretions in the upper airway or the tube, coarse crackles on auscultation, or deteriorating blood gases. In pressure-oriented ventilation, you will notice the tidal volumes drop with increased secretions. In volume-oriented ventilation, you will notice increased peak inspiratory pressures with increased secretions. So step 2 is to assemble the appropriate equipment. So you want to have your suction catheter open and attached to the suction, ready to go. Have your suction ready, set on regulated, and turn to the appropriate suction level. Your suction tubing, and you'll have a collection bottle also on here. And for open suction, you'll have to use a sterile glove for handling the catheter, and your other hand will have a glove on it, but it will be clean. Step 3 is pre-oxygenation. So on the Servo I, it has a feature called suction support, which makes it really easy to suction. So you go to quick access, suction support, and for the neonatal population, you want to increase your FiO2 by 10 to 20%. So if they were set on 50 before, you would change it to 60 for pre-oxygenation. So hit accept, and now it will give 120 seconds of that selected FiO2, which was 60%. When you disconnect the baby from the ventilator will go to standby. And at this point you can suction the baby, and when you're done you reconnect, and now the ventilator automatically goes into post-oxygenation or re-oxygenation, and it goes to that same FiO2 that you set, and it'll give it for 60 seconds. If that 60 seconds runs out and you're still on that increased FiO2, it will go back to the original FiO2 you had set. So at this point we're just going to cancel that. Okay. So when you go to insert the catheter, you want to make sure that you're going to the correct depth. In a baby, what you want to do is insert the catheter to the end of the endotracheal tube, not until you feel resistance. So to calculate that, for open suction, you will use the formula length of the ETT plus 3 centimeters. The plus 3 centimeters is for the blue connector on the ETT. 3 centimeters is from the tip to the other tip. So on this one it would be about 6.5 plus 3 centimeters for suctioning depth. In closed suction, you use length of the ETT plus 5 centimeters for the closed suctioning adapter, which is a little bit longer. When you're applying the suction, it should only take 5 to 10 seconds to withdraw. And while you're suctioning, you want to position yourself so that you can see the monitor easily. And if any adverse effects occur, you should stop suctioning right away. So after you're done suctioning, you should reassess the patient. You just want to do a basic ABC. Make sure you auscultate. And you can only use the same open suction catheter 3 times. After 3 times, you should change it. And then to finish up, you just want to clean up and document. So you'll wrap the catheter inside your glove, and we'll demonstrate that after. And you want to document what you saw when you suctioned. So you want to document things like amount of sputum, color, thickness, and the amount of times the patient was suctioned. Now we're going to demonstrate open suctioning on the neonate. So at this point, we've already assessed the patient, determined that they do need suction. We've assembled the equipment. We have the suction catheter, the tubing, the suction regulator. And we have our sterile glove and our clean glove on. So now we're going to pre-oxygenate. So we'll go to quick access, suction support, 10 above what we have set. We'll accept that. So now the baby is being pre-oxygenated. So at this point we would observe the monitors. Are we done? We'll observe the monitors and wait for the sats to rise, and if they plateau, then we know the baby is ready to be suctioned. So now the sats have rise to an acceptable level. So we'll take out the suction catheter from the packaging, making sure not to ruin the sterility of it. And I'll get my assistant to remove the ventilator. As you see, it has gone to standby. So we'll hold the tube with our clean hand, and we'll insert the suction catheter with our sterile hand to the level that we've already determined. We'll say it was 11 centimeters. So we'll insert it to that, and then we'll apply the suction, taking 5 to 10 seconds to withdraw. Now my assistant will reconnect the patient, and as you can see, the ventilator has automatically gone into reoxygenation. So at this point, we'll wrap the glove up to make sure that it doesn't hit anything and lose its sterility, and we will reassess the patient. So we want to make sure no adverse effects have happened during the suctioning. And also, while you're suctioning, you want to always watch the monitors and make sure that no bad effects are happening due to the suctioning. So at this point, we can remove the suction catheter from the tubing and just wrap it up in our glove like that, and then throw it away. And we also want to make sure that we document what we saw when we suctioned. Now we're going to demonstrate how to properly close suction in neonate. So to start, we want to quickly disconnect the neonate, remove the original ETT adapter, and put on a closed suction ETT adapter. This one is a size 4. You want to correlate that with the size of the tube. So if the tube's a size 4, you want a size 4 adapter. The ventilator goes on this port here. And the suction goes on this port here. Okay. So on the suction catheter, each color is correlated with a number for ease of use. So what's going to happen is you'll calculate how deep you're going to go, and you will see a color that correlates with that. When you're inserting the catheter, you want to watch for the color to come out here. when you see that color, you're deep enough. Okay, so we'll say that we've already assessed the patient and they do need suctioning. The suction level has been set and we have our clean gloves on. It doesn't have to be sterile for this one. So what we'll do is make sure we support the tube, and we'll make sure that the lock is off. Right now it's on. I cannot compress and make the catheter suction. So now the suction is on. So the suction will not be applied though until the button is compressed. So you want to, with closed suction, you also want to pre-oxygenate. So you can do that on suction support, the same as open suctioning. So we'll set that the same as we did for open suctioning, which is 10 above. So it was originally 50, we're setting at 60. We'll accept that, and now it gives the pre-oxygenation for us. So now what we want to do is we've calculated how deep we want to go. We'll say we want to go to the blue marking. So we'll begin to put the suction tubing in. We're watching for the blue color. And there, you can see the blue now. So now what we want to do is compress the button, and we want to withdraw, making sure the tube is supported and watching for any changes on the monitor. You want to make sure that the tip of the tube is withdrawn far enough away that it's not going to obstruct the flow of the ventilator. So now the ventilator has automatically gone into reoxygenation, and we want to reassess the patient and make sure no adverse effects have happened. At this point, you want to turn the suction back on lock so it cannot be compressed by accident, and you want to document what you saw when you suctioned.